Thank you for that lovely introduction. Can people hear me? Great. There's a few seats at the front, by the way. There's 3 seats I can see, so if anybody's interested. Okay, I have a clicker. So I'm Sigal. I work for Guy's and St Thomas NHS Trust, but I also work for the Artificial Intelligence Centre for Value-Based Healthcare, which I'll talk a little bit about. So I think people know what the NHS stands for, but it's the National Health Service in the UK, and it's free at the point of care, millions of patients, and in my organisation alone, we have over 23,000 employees. So just to give you the scale of that, of Guy's and St Thomas. But actually, as part of the AI Centre, we are a consortium of organisations. So there's 10 NHS organisations, there's 4 universities, those who are leading in medical science and biomedical engineering. So it's mainly led by King's College London, Imperial University College London, and Queen's Mary universities. And Guy's St Thomas and King's College London are kind of, we have a joint campus where academics, clinicians, and technologists work together on driving some of these solutions I'm going to talk about today. And really our mission is to transform healthcare through utilizing of some of these new technologies. And we're supporting the whole AI lifecycle. So the way we're doing that is from the collection and standardization of data to in a protected and safety, observing patient privacy and opt-out as well. And that allows us to train, because the data is transformed, curated, and safe, we can train those models of AI. I'll explain a little bit about the technologies that we created through that and deploying it in actual patient workflows. And again, I'll give some examples of some of the things we've been able to do. And all of that is also, some of these technologies are available in the marketplace, and we're developing some of the standards and frameworks together with international organizations to scale that across the National Health Service, but in fact, scaling that internationally. So a couple of our technologies are actually available in Amsterdam and Utrecht Hospital University Medical Centers, I think they're called. So I spoke a little bit about that. So we were funded by the government to actually deploy some hardware within the hospitals that allowed us to train models with high GPU. We created some software solutions. So one of them is the federated learning interoperability platforms that allows us to actually train models without the data actually leaving the healthcare organizations in a secure enclave. The second one is the AI deployment engine, which then enables us to actually deploy that in a clinical pathway. And another technology called CogStack, which is a natural language processing and machine learning technology that again allows us to unlock patient records that are usually in electronic health records in a much more elastic way to derive concepts from those medical records in a much faster and kind of easier way. And we also have a regulatory infrastructure, so we have governance for those projects, so that data, so the people who sit on that are clinicians, researchers, information governance, Caldecott guardians, and patient representation to allow these projects to go through with the right data in a safe way. One of the panels today will be about safety and privacy, so I think that's a really important topic. This is just to talk a little bit about MONAIS, the Medical Open Network of Artificial Intelligence. It's an international collaboration that actually, very happy for you guys to check that out. It's online and it has some of the framework that I use to deploy AI in it's open source as well. I think it's also really important to talk about capabilities within the healthcare services. So we teamed up with Health Education England and the Department of Health and Social Care to fund 12 months fellowship for clinical medical professionals who are also part-time data science and AI. So we train them and they actually work within the hospitals and with the academic partners on real-world projects. So this is part of really kind of looking at our workforce and how do we change what we do to enable these colleagues to work in a way that that allows them to understand a lot more about AI and deploy it in clinical care. So I'm going to give some examples. I was going to have a video, but actually that doesn't work. So I'm going to talk a little bit about the first example that I'm going to give is a stroke AI model that we developed in King's College Hospital in King's College London. So it's called the intracerebral hemorrhage phenotyper. And really what it does, it's this is kind of a little capture of the CT scan of a brain of an anonymized patient, and you can see that the white bits are the bone, you can see the eyeballs, and there's a hemorrhage at that front area that's here. The report that the AI generates enables that kind of masking of showing where the bleeding is in pink, but it also, very importantly, gives a report. I'm sorry, it's really not clear here, but it gives you a real breakdown of which areas of the brain are affected, and that is enabling the clinician to really have an understanding of what's the downstream treatment that the patient needs to have, and allows us to plan the right therapies that will help them after their stroke. So this is one example, and this is live and available already for clinicians, and they're using it in King's College Hospital in London. Another example is this auto-segmentation of contouring organs for radiotherapy. Again, we developed this at Guy's St Thomas from, I think it's actually some hospital in Norway that developed the original code, and that was developed further through the internal teams at Guy's St Thomas. And again, it just automatically contours the organs so that the radiotherapy can be focused on the areas that are affected and not affect healthy tissue. And that kind of reduces the time that it takes a radiotherapist to do that from 30 minutes to 3 hours to 20 minutes or less for this to work. So that's a real, we can see that the turnaround time has been reduced by 75%, and that's really, helping us to free up a lot more time to treat patients. I wanted to give an example as well of a more population health project that we've done. So this is using the natural language processing, CogStack, MedCat technology, and basically looking at refractory epilepsy, which is epilepsy that does not respond to medication. And we looked at around 40,000 patients over 10 years, and were able to really quickly, through this tool, the NLP tool, to derive concepts that enable us to develop this model that detects and predicts how patients will react to drugs and enable us to treat them more effectively as a group. So that's another example project. And this is actually, the technology is now available, as I said, in UMC Amsterdam and Utrecht. So they are using CogStack and MedCat to do a number of NLP projects. Another one that is really interesting is kind of the clinical trials feasibility. So again, in this case, for researchers and companies that want to identify a cohort of patients for a clinical trial, they're able to really quickly look at, run a search on key criteria that they need for their research, and the patient cohorts comes up, and the electronic health record system flags up that patient as a trial candidate, and that really speeds up the time for patients to be able to participate in this and benefiting from new drugs and treatments. And another, I thought that it's also worth just mentioning another kind of more operational side of things. So again, waiting lists for cancer and for many conditions are really long. And one of the things we need to do is really identify where people are really at risk. So again, through the NLP tool, we're able to score patients based on clinical priority criteria and make sure that the ones that need urgent care are prioritized first, again, automatically. And then those that don't need as much treatment or even final treatment, we can close some of these waiting lists down. So this is really important for us in terms of capacity management within hospital trusts and wider areas. So I'm giving kind of a lot of different examples of how these type of technologies can be used. So hopefully this gives you a little bit of a snapshot. I'm not sure where I am with time. Actually, I'm okay with time. That was really quick. To give you an idea and a breadth of how we use internally these technologies. I think it's really one of the things that have enabled us to work so effectively is the fact that we have these technologies in-house, that we're able to invest in, as I said, that kind of juxtaposition between academic, data science, research, clinical people on the ground who know what the problems are, and that kind of technology, infrastructure, and innovation. So I just finally wanted to talk a little bit about my colleague, Dr. Hamad Khan, who's a neonatalist. He looks after very unwell babies. And he came to us and said, we have a problem with babies who are born prematurely, where they're at a real risk of abdominal perforation, where they basically have a hole in their belly, and we need to identify that really quickly so they can be treated. It's a fatal condition. So we're training models. There's not enough data because thankfully, not too many babies get that, but it's a very common condition for babies who are premature because they're at risk for that. So again, we're able to develop those algorithms with Great Ormond Street Hospital and lots of other hospitals that treat babies to get enough data to train the models accurately. So again, one of the things that we do through these collaborations with lots of hospital trusts is that we're able to train models across a range of data, not just in one hospital. As you probably know, a lot of the issues that you have with AI models is once you bring them in, even once they're available in the market, when you validate them on your own patient data, it's not always accurate. It doesn't work as expected. So that's another really key factor in what we're trying to do. So I think that's it. I think I'm finished with my actual slides. And I don't know if we want to take questions.
Yes, thank you. Thank you, Sigal. So we've heard so much about how clinical workflow, from infrastructure to policies, and some concrete examples. Do we have any questions in the room for Sigal? First, and then two questions.
Thank you so much. Miguel Ventura from the pharma industry here, AstraZeneca as well. Very pleased to see this presentation, and we definitely want to invest also in these kind of use cases for clinical workflows, clinical trials. At the same time, I would like to ask you the question, are you investing as much in AI use cases capable of auto-leading the frameworks for the consent, compliance, regulatory with the clients in this regard? And how far do you think we are until AI is capable of doing that by its own and automating all processes for this clinical and patients' data? Thank you.
Wow, that's a good question. I think that the regulation needs to catch up. The regulation that is really critical here is software as a medical device, for example, and of course the GDPR and all the kind of regulation to preserve patient data. It's doable. The way to remove the risk is to comply with those rules, but it's very onerous. It takes a long time to go through these governance and make sure the data is curated in the right way. I think it could be speeded up. I think it needs more than one organization. Obviously, as I said, the AI Center is a consortium, but it doesn't necessarily include the regulators. We're trying to influence regulator, but it needs, people like the people in the room probably and wider to really come together and influence policies, and not just in one country. The EU new AI Act is really important in that, but healthcare is quite a specific sort of area of that. And I think actually companies like AstraZeneca has a role to play in that. So we're actually working with Number 10 Downing Street to actually create AI workshops that will address that. There are some, I think there are more nuanced rules that need to come to place, but already there's quite a lot that can be achieved. So there's a bit of a balance, but at the moment we have to invest quite a lot to get, the examples I gave, some of them are fairly easy because we have that, the data is there, the technology is there, and we can just do the NLP stuff. Other things are a bit more complicated. The imaging side, for example, we're starting to work on genomics and pathology. Some of the standards there don't quite exist yet. There's not specific ways of looking at the data. There's challenges.
So we take one more question.
Thank you very much. Very interesting. Paula van Brakel from the Pharmaxis Foundation. I have a question on the rheumatology prioritization method. Because as a patient, it can be in my disadvantage to participate in it, right? How do you deal with that? Is it like mandatory to participate to get access to the treatment, or how does that work?
That's a good question. So actually, with waiting lists, usually this is we're trying to improve people to be seen more quickly rather than less quickly. It's for direct care, so you don't get to, it's part of what we're trying to do at the back end of the hospital to make sure that people that really in critical condition are seen first. So there's no, it's not really, I guess, a choice to participate in that. It's just one of the tools that we use. It's not the only tool that we use. But certainly as a patient, you have a right not to take part in research, not to take part in certain things, but in terms of the operational activity, we deploy as many tools as we can, and this one is
so the decision
helping us.
Is with the hospital.
How we run the operational activity. So you're right to say that as a patient, we're all patients, in one hospital or another. So we don't really have a choice how the hospital determines that. But hopefully the AI will pick up on those critical things because they should be part of the patient record.
Sigal, in our conversation just before your presentation, you mentioned how hard is the trade-off between human and AI. So now we're enabling hospitals with more and more AI. Can you tell us a little bit about that balance? How do you find the balance between investment in technology like AI and investment in healthcare workforce?
Thank you. I think there's not enough of either. If you ask me. But I suppose one of the ways that we can look at it is really the kind of digital maturity of workforce and how I think we need more investment in technology, but not just in pockets. So at the moment, in England, at least the government invests in timeline projects. So 2 years you get investment, but it's not continued. So as organizations that have our own priorities, I think we do need to invest, both in terms of infrastructure we build and the technology that we adopt, but also in the capabilities that we develop within our workforce. And what we're doing at the moment, for example, we're funding these type of fellowship posts, but we're funding actually some of our clinicians who want portfolio careers and have a lot of burnout working in the hospital who have data science skills to do part-time in both. And that really means that we have a workforce that really has a deep understanding of the data from a clinical perspective, but also it can do the coding, the training of the models, etc. So it's a really fascinating area, and I hope that we continue to develop it.
Thank you, Sigal. Thank you so much.